Excellent timing, Piper. All right, folks, we can probably go ahead and get started this morning. Looks like Piper's joining us, but I'm not sure if she's able to actually turn her um, mic on or not. So, oh, there she is.
My camera this morning. I'm just gonna.
Gotcha. No worries. So we'll go ahead and get started, and if more people trickle in, I will just let them in. Today is a special day. We don't have a case presentation today. Instead, we have Dr. Kim Mueser joining us for the full hour and a half to talk with us about trauma and psychosis, which is a topic that so many of you have expressed interest in and have had dealings with. And the folks that we work with, trauma is often present, right? And how does it interface with psychosis? How do we deal with it? How do we identify it? So I'm really looking forward to this today, and I'm hopeful that you all have good questions and that we can kind of engage in more of a discussion as well after his presentation. But we'll go around and do introductions just like we normally do, and then I will turn the floor over to Kim. So I will start today and introduce myself. I just realized I didn't have my video on. Sorry, guys. My name is Carissa Coudray, and I have worked with Piper in the Department of Psychiatry now for 5 or 6 years, doing research and research coordination. And I also do clinical work at the Navigate Clinic. And Piper, do you want to introduce yourself?
Sure. I'm Piper Meyer-Kalos. I'm a clinical psychologist and also an IRT at the St. Louis Park team. And I'm one of the original developers of the IRT manual with Kim, actually. So I'm excited to have him here, and I'll do a little more introduction when everybody finishes. Oh, and I'll pass it to Hope.
Hi, I'm Hope Robertson. I'm one of the new interns at the Strengths program for my Foundations or Generalist internship. And I'll be doing more of the SEE parts of Navigate. Thanks, Maria.
Morning, everyone. My name is Maria Vaudrey. I'm a student IRT with the Adult Strengths program at Riverside, Minneapolis. Melissa.
Hi, good morning. I'm Melissa Roseball, and I am the social work care coordinator on the Navigate team in St. Louis Park. And I'll pass it to Orly.
Thanks, Melissa. Good morning, everyone. I'm Orly Haven, family clinician at the St. Louis Park Navigate team, and I will pass it to Laurel.
Good morning, Laurel Bieschke. I'm the outgoing program manager over at the Compass program at Radius Health in St. Paul, and I will pass it to Sarah.
Hi, good morning. I'm Sarah Ewing, and I'm the ingoing program manager, at Radius. Last name is Ewing. Sorry, I don't have that up there. Sarah Ewing. And I will pass it to Maria. Maria already went.
I already went, but
I'll pass it to our doctor, Kim.
Oh, we'll do him last, but how about we do Kayla?
Oh, great. I can't see everybody's names. I'm so sorry about this.
Okay.
My first time.
No worries.
So
Totally
to
okay.
Kayla. Thank you, Kayla.
I'm Kayla Colson. I'm the program supervisor for the Child and Family team up in Duluth at the Human Development Center. And I also oversee the FEP team and provide the family education and IRT services as needed. I will pass it to Vic.
Hi, I'm Vic Ornstein, and I am the peer specialist on the HOPE team at HCMC. And I'll pass it to Elizabeth.
Morning, I am Elizabeth. I am the IRT at the HOPE program in Minneapolis. I'll pass it to Amy.
Good morning, everyone. My name's Amy. I'm an IRT, doing some IRT at the Navigate program in St. Louis Park. I will pass it over to Stephanie.
Hi, I'm Stephanie. I am the Supportive Employment and Education Specialist with Navigate at the St. Louis Park location. Orly, have you gone yet?
Liz.
Or Liz? Okay.
Oh, Liz, can you hear us? She might have stepped away. Okay. So before I do a quick little introduction for Kim, I do want to give a little shout out to Vic. So hopefully everybody saw Vic present a couple of weeks ago. We were so pleased and so happy that she was able to do that for the conference. And I just wanted to give her a little shout out. And if Nancy was here, I would do the same. So hopefully everyone saw Nancy present last week. We had quite good representation from Minnesota at the conference. So it was quite a success and we got a lot of good feedback about it. So I want to introduce my esteemed colleague, Kim Mueser, who is a colleague and mentor of mine. And I was really excited that he agreed to present. And we talked a little bit about what kinds of questions you all were coming up with trauma. And I'm really hopeful that what he's going to present today is going to be really helpful. And I encourage you to ask him questions. And I think there'll be some time if you've got some cases that you've been feeling stuck with. He is the person I typically go to, by the way, when I get stuck. So he's really good and helpful, especially around trauma stuff. So Kim, I'll let you do a little more introduction, but thank you for joining. I'm going to stay for a few minutes and then I'll probably hop off.
Great. Well, thanks very much, Piper and Carissa, for the introduction. I'm really happy to meet, see everybody on the Navigate teams here. And I have tried to make this presentation as practical as possible. To give you a little bit of background, I know many of you, but probably not all of you, attended the Second International Navigate Conference. And for the second day of that, I did do a presentation on this same topic. And so what I've done has been to do some editing of my slides and to do some additional slides, in particular, slides related to distinguishing delusional versus real traumatic events, kind of how to make that judgment, as well as more in terms of getting at trauma-related thoughts and beliefs and helping people challenge and change such beliefs. I think in order for the presentation today to be as useful as possible, what I'm going to do is to encourage questions as I go, rather than going all the way to the end. Hopefully, if we do that, we'll still have some time at the end, for example, to talk about cases or whatever. But what I will do is to stop at particular juncture points just to see if there's any questions. If there's not, that's fine. I'll keep going. But it might make sense to ask a question about assessment, after I've talked about assessment and so on. So I think if we have that flexibility to allow questions, hopefully it'll be as useful as possible. So with that as a background, let me share my screen. And I've told Carissa that you guys can have copies of my presentation, of course, so you'll be able to get that. Can everybody see it?
Yep, we can see it.
Okay, great. Okay, so oh, I always forget that there's weird ways of advancing it in Zoom, but I think I figured it out. Okay, so what I'm going to do is talk just a little bit about trauma and PTSD in people with serious mental illness, as well as first episode psychosis. I'll then just very briefly touch on the trauma of psychosis, but because the trauma of psychosis is covered pretty well in the Navigate manual, and because there's a specific module focused on that, that is really aimed at reducing PTSD-like reactions to psychotic symptoms, I'm not going to go into more detail on that, although I have included the slides for how to treat the trauma of psychosis in Navigate, so that people can kind of review that on their own. But I'm not going to go into detail about it today. I'm going to then talk about PTSD symptoms and associated problems. I'll talk a little bit about questions in terms of distinguishing PTSD symptoms from psychotic symptoms, or when both may occur. I'll then go into the assessment of trauma and PTSD, and in particular, the assessment based on using the tools that already exist in the IRT manual. And then I'll get into the treatment of PTSD in Navigate, also focusing on tools that are available in the Navigate manual. And I will make reference to a few additional tools that are easy to get that can supplement the materials in the IRT manual. Okay, so with that as background, when we're talking about trauma, generally we're referring to the DSM-5 definition of trauma, which says an event involving some direct threat of death, severe bodily harm, or psychological injury to the self or another person. And the common traumatic events that lead to post-traumatic stress disorder are events such as rape or sexual abuse, combat, accidents, physical assault, or physical abuse, natural disasters, or the sudden unexpected death of a loved one. And if we just talk about the importance of trauma for people with the first episode of psychosis and schizophrenia, trauma and other adverse childhood events increase the risk of developing a psychosis. And we actually know that people who have a psychiatric admission or a psychiatric diagnosis of post-traumatic stress disorder are more likely to then have a subsequent psychiatric admission for a first episode of psychosis, as well as for bipolar disorder. This has been shown in large cohort studies done in Scandinavia. So that we know, because early childhood trauma, of course, increases the chances of a person developing post-traumatic stress disorder and a serious mental illness, and because the onset of PTSD on average tends to be relatively early. For that reason, PTSD actually predicts later onset of psychosis. We know that there are high rates of trauma in people with psychosis, and that trauma occurs both before the onset of psychosis as well as after the onset of psychosis. And we could talk about that if people are interested, but because we're talking about first episode of psychosis, I'm not going to go into that so much right now. We know that people with a trauma history tend to have more severe psychiatric symptoms, psychotic symptoms, and other type of symptoms, especially depression and anxiety. I mean, that is almost certainly the strongest correlate of trauma history and post-traumatic stress disorder. Another thing that is worth noting is that psychotic symptoms can occur secondary to PTSD. There isn't really anything on this topic in the DSM-5, but there is a modest research literature showing, for example, that people with PTSD who don't have another, say, a psychotic disorder like schizophrenia or psychotic depression, but people with PTSD are more likely to have hallucinations, usually mild hallucinations, frequently, but not always, trauma-related. And they often have mild delusions, thinking that kind of people are kind of out to get them, giving them a hard time, and those kinds of things. And we know that the more severe the PTSD symptoms are, the more likely it is for a person to have at least mild psychotic symptoms. This can sometimes lead to a misdiagnosis of schizophrenia or a psychotic disorder. We're probably not going to go into that in a lot of detail, although we could discuss it. But what I would say is that if a person has really severe PTSD, that treatment can certainly reduce the PTSD and can sometimes can often reduce the psychotic symptoms. And in some cases might lead to identifying somebody as actually having had a primary case of PTSD and not even a first episode of psychosis. That probably doesn't happen that often, but it certainly happens occasionally. This just summarizes the rates of PTSD in people with severe mental illness, and it's a rather busy graph to see, so I'm going to summarize it really quickly, which is to say, talk about samples of people with serious mental illness, like who have had repeated episodes. Most of the studies show that the rates of PTSD are somewhere between 25 and 50%, kind of, hovering in the, say, 30 to 40% range. If you look at the rates of PTSD in first episode psychosis, they are somewhat lower. The estimates ranging from about 5% to 16 or 17%. And that is still higher than the rate of PTSD in the general population, but less than people with serious mental illness. And it may be that at least some of the PTSD that develops in people with serious mental illness develops after the onset of the psychotic disorder. The next bunch of slides go into the trauma of psychosis. And as I said, I'm not going to get into that, but just very briefly so people know what we're talking about here. We also know that the experience of psychotic symptoms like hearing voices or having delusions, and we also know that certain treatment experiences like involuntary hospitalization, coerced treatment, being put in seclusion and restraint can in their own way be experienced as traumatic events and can lead to PTSD symptoms. We have sometimes referred to this as a PTSD syndrome rather than PTSD symptoms because there's some debate as to whether technically these would be considered traumatic events according to the DSM. But we do know that the experience of an onset of psychosis and treatment-related experiences can be traumatizing to individuals and can lead to distressing PTSD symptoms. And within the IRT manual is a module that takes a narrative approach to helping people process their psychotic experiences, challenging certain negative self-stigmatizing beliefs about having an episode of psychosis and so on. And that's really very well spelled out in the manual. So I'm not going to go into any more detail about that here, although there are a bunch of slides. Actually, the slides come a little bit later. Right now, let's just talk about the DSM-5 symptoms of PTSD. So there has to be exposure to a traumatic event. And not, clearly, you can have exposure to multiple traumatic events. But the way that PTSD is assessed is that you look at the distressing reactions that a person has to a particular event called an index event. Now, this event can be several events of the same nature because certain types of events, in particular sexual abuse and sexual assault, can occur repeatedly over a period of time. And so a person may have several memories related to a type of event. And in that case, what we do is we assess the kind of reactions to those memories. Most commonly, by the way, a person might have memories of anywhere from 1 to 3 or 4 or 5. You can even have between 5 and 10. It's rare for people to have more active memories of traumatic events, more than say 5 or 6 of a particular type of traumatic event, even if it had happened many times. So you have the exposure to the traumatic event, and then you have 4 clusters of symptoms. And you need to have at least some symptoms from each cluster in order to make the diagnosis of PTSD. So the first symptom cluster is called intrusion symptoms. And this includes intrusive memories of the event. So this is like when a memory of the event pops into the person's head, kind of when they're unexpecting it, and typically leads to distress. Flashbacks is another symptom. A lot of people confuse intrusive memories from flashbacks. The difference is that when a person has a flashback, they're temporarily re-experiencing the trauma as though it happened again. There's a dissociative quality to it. So very, very typically, very briefly, it's as though the event is happening again. as opposed to an intrusive memory is most commonly kind of a mental picture of what happened, although there are such things as physical memories and the like. The person can also have nightmares related to the event. When people have nightmares, they tend to be loosely thematically related to the traumatic event. They do not tend to be a simple repetition again and again and again of the traumatic event. Of the intrusion symptoms, intrusive memories of the event are by far the most common. They're probably the most common PTSD symptom of all of the symptoms. And I don't think I've ever really worked with somebody who had PTSD who didn't have that as a key symptom. And if you're working on assessing somebody and that isn't a problematic symptom, that should be a warning sign to you that maybe the person doesn't have the PTSD. Okay, the second cluster is avoidance of trauma-related stimuli. So people avoid memories. And in fact, you get certain, like sometimes self-injurious behavior, like in, you can get it in first episode psychosis and borderline personality disorder, but self-injurious behavior, at least for people with PTSD, is sometimes aimed at avoiding essentially or dealing with upsetting memories, trying to get them out of one's mind by reorienting to something in the here and now and painful. People may avoid people, situations, and other kind of things that reminds them of the traumatic event. The third cluster is over-arousal symptoms. So people often feel on edge, hypervigilant. There's an exaggerated startle response. They often have difficulty sleeping. They want to sleep and often feel extremely fatigued, but have a lot of trouble falling to sleep, especially, and staying asleep. They may also have anger outbursts associated with this over-arousal cluster. And then the last set of symptoms, and this is the set that was just added in the DSM-5, are negative alterations in cognition or mood. The person may be able to, may not be able to remember parts of the event. They may have persistent negative feelings, guilt, depression, anxiety. They may feel detached from others. And there may be a cluster of kind of negative beliefs in terms of self-blame for the event, not having a future, and so on. But you need to have some of each of those different types of symptoms. Let me just make one or two comments. A person can have hallucinations, and the hallucinations could be clearly trauma-related, in which case they would be considered both hallucinations, but intrusion symptoms. And so that's kind of the issue of that. And a person may be a little bit paranoid, but avoiding things that remind them of events, and therefore there could be some evidence of delusional beliefs that actually overlaps with the avoidance symptoms of PTSD. In general, if you inquire into these symptoms and look at the association with the traumatic event, distinguishing the symptoms from symptoms of a first episode of psychosis is not that difficult. Let me see what our next thing is. Oh, this is this associated problems. Depression is quite consistently the most common associated a symptom related to PTSD. In fact, in the general population, about half the people with PTSD actually experience a major depression. Suicidality and self-injurious behavior are common. There certainly are significant risks. I've already talked a little bit about psychotic symptoms, hallucinations, mild delusions. Substance use problems are also common. People will frequently self-medicate to either escape memories, to get to sleep, and things like that. Okay, so before I go in, the next thing I'm going to get into are the practicalities of assessment of PTSD in people with the first episode of psychosis. But let me stop just for 1 minute and see if there are any questions about just the diagnosis of PTSD, kind of the characteristic symptoms.
I do have a question. Oops. So I have a lot of individuals who, when I go through this with them, they have a not everybody, but some people have a really hard time understanding flashbacks. Like, even if I'm like saying like it's as if you were there again. I've had some people be like, yes, that's exactly what's happening. Then they'll describe it and it's not a flashback.
Right.
Do you have suggestions? So 2 questions. Do you have suggestions of how to like actually pinpoint and help somebody understand what a flashback is? I've had some struggle with that. And then secondly, you know, you had also said that like positive psychosis can be intrusion, which makes tons of sense to me. How does that relate to flashback as well
Okay.
in terms of psychosis?
Those are great questions. First of all, you're doing exactly the right thing when somebody says, yes, they have a flashback, and you kind of explain it to them. And as it turns out, they're actually having an intrusive memory. And that happens, that is really, really common just with anybody with PTSD. So it's common in both first episode psychosis as well as just in the general population. The real issue is to see, you're doing correct in terms of saying, oh, a flashback is as though you are experiencing it at the moment. If the person doesn't indicate that they've had that experience, it's fine to just move on. In my experience, real flashbacks where there's a dissociative quality, the person is temperate, they're really quite rare. And so when people say they have flashbacks and then you do a clarification and it's really an intrusive memory, acknowledging that and saying that's fine. And then I think moving on is perfectly fine, because it is a rare enough symptom that when it occurs, you can usually distinguish it. People will say that, and then you can kind of acknowledge it and explain it. And when it doesn't, chances are it's not a big thing. The other thing about flashbacks is that when people have a lot of flashbacks, there aren't any particular things you would do differently in terms of the treatment of the PTSD. Every once in a while, you get people who have like common dissociative experiences like flashbacks, and then you have to deal with how you're going to approach that from a cognitive restructuring perspective. And I could get into that if people are interested, but it's really relatively rare. The second thing, the second question was about when you have like hallucinations that are also re-experiencing symptoms. Is that true? Okay, so the difference between a hallucination and a flashback is that in a hallucination, the person is generally speaking oriented to the here and now, but they are having a sensory experience like hearing voices, but it could be seeing something that's not in the here and now. But as long as they are oriented to kind of where they are and when they are, as opposed to temporarily being transported back to the event itself, it is still a hallucination and not a flashback. And it may also be a re-experiencing symptom if it's clearly related to the trauma. Does that explain it?
Yes, thank you.
Sure. Okay, so I'm going to keep going because we're going to get to all sorts of other kinds of stuff. Okay, so these slides are just the treatment of PTSD kind of reactions to first episode psychosis. They're all in the manual. People can look at the slides, or they may have seen them already, but there's no need to go into them here. So now let's talk about the assessment of trauma and PTSD that are not related to either psychotic symptoms or treatment experiences. One thing, and I think I have this somewhere in the slides, but our recommendation is to do this assessment after establishing some rapport with the client and after working with the client maybe a month or two or something like that in IRT, so that the primary psychotic symptoms and other symptoms that the person has experienced have been reduced and stabilized pharmacologically. What we found in the RAISE study is that when we assessed trauma and PTSD at entry into the program, even though we saw pretty high rates of trauma, the rates of PTSD were not that high. They were actually only about 5% in the sample. And our thinking is that the experience of psychotic symptoms, the process of going into a hospital, receiving treatment for a first episode of psychosis, these experiences may be overshadowing the presence of PTSD that actually exists in some of the people. And so waiting for the most acute symptoms to reduce getting pharmacologically stabilized to some extent, and then assessing trauma and PTSD, I think is probably more fruitful for identifying a PTSD. I think that's probably the way to go. The one exception would be if somebody comes into the program and the most prominent symptoms they have really are PTSD. And there's psychotic symptoms too, but the PTSD is kind of screaming at you from the very beginning. Well, then I would assess the PTSD. And if it's clear and present, as soon as things get a little bit stabilized, I would prioritize the treatment of the PTSD. It could even be a case where the psychotic symptoms are secondary to the PTSD. But in most cases, what you have is kind of the prominence of a first episode of psychosis, and PTSD may be lurking in there, but it's not kind of screaming out at you. Okay, so having said that, I think it's important to kind of accept that there's no typical person with either a first episode psychosis or serious mental illness who has PTSD. And by saying that, what I mean is that clinically, you can't count on picking up PTSD without doing routine screening. And I say that, as somebody with experience and experience in terms of having been surprised in working with a client who I thought had a different disorder, who, as it turns out, had PTSD, but I didn't know it because I didn't do a routine screening. So for that reason, once things have settled down and you're working with somebody and you've done some work, maybe even after you've completed the processing the psychotic episode, I think doing a routine screening for PTSD is the best way to go. There are measures that are contained within the IRT manual for doing this assessment. The only thing you really need to do in terms of preparing the client is to just explain that you want to spend a few minutes talking about some difficult life experiences that they may have had, and that it's important for you to understand any experiences that the person might have had in order to give the person the most effective treatment. So you need to kind of say something before you begin, before you give a questionnaire out or before you begin asking questions about trauma, but you don't want it to be really long-winded. You don't want to say it in advance or people will kind of obsess and worry about it. You just want to give a kind of a matter-of-fact explanation that you're going to ask some questions about some difficult things that might have happened. When you talk about trauma with people, it's important to avoid using certain emotionally laden or loaded words like abuse or rape, unless the person uses those words themselves to describe an experience, in which case it's perfectly fine. But the reason for doing this is that people don't necessarily construe experiences that may be traumatic in nature as necessarily fitting these criteria. So you will often see in surveys of people who have been sexual assault victims that significant numbers of them do not report having been raped. And that's because the word may mean certain things. It's loaded in certain ways. So trying to be a little bit more behaviorally specific and avoiding those kind of words can be helpful. So when it comes to assessing traumatic events, there's a questionnaire, which is an abbreviated questionnaire that has 16 items about different traumatic events that the person may have experienced in their lifetime. And they're asked to simply indicate whether or not they experienced each event. This questionnaire can be administered by interview by the clinician, or it can be given as a self-report questionnaire, and then the clinician reviews it. After going through the different questions about the traumatic events, and this takes like 5-7 minutes, something like that, what the clinician asks the person to do is to identify the event that is currently most distressing to them. And the reason you're asking for the event that is currently most distressing is that PTSD is a disorder of the present, not of the past. And so even if something may have been more upsetting at the time that it happened, the unfinished business associated with PTSD is what leads to high levels of distress in the here and now. So you ask for which event, or if it's something like a childhood physical abuse or childhood sexual abuse, which type of event is currently most distressing to the person. And then after identifying that, you ask the person to complete, or you can do this by interview, the PTSD checklist called the PCL-5. And this is a set of the 20 DSM-5 PTSD symptoms. And the person indicates how much distress these symptoms have been causing them recently over the past month. And the clinician writes in for the client the event or the group of events that the person is rating their PTSD symptoms to. So when you're assessing PTSD, the PTSD symptoms are always linked to either one particular event or a set of related events. And each of these events is then the person indicates the amount of, each symptom, the person indicates the amount of distress that they've experienced related to that symptom over the past month. And it's on a 5-point scale. And a total PCL score of over 45 indicates probable PTSD. Scores over 40 may certainly indicate possible PTSD and may be worth exploring further. The PCL has very good reliability. It's been used in lots of different populations, and it has been used quite a bit in the population of people with a first episode of psychosis or a serious mental illness, and it's known to be strongly related to a structured diagnostic assessment of PTSD. As I'll describe a little bit later, we also use the PCL to monitor effects of treatment for PTSD for the person. I'm going to do this next slide, and then let's stop for a few questions about a diagnosis. So the PCL, the PTSD checklist, if the person has a high enough rating, indicates that the person probably has a PTSD. And if that happens, the clinician should spend a few minutes reviewing with the client, kind of verifying their understanding of the most distressful event experienced. They might have done this earlier, but if they didn't do it earlier, they should do it now, as well as what the most distressing symptoms are. Here, it's important to point out that when you are reviewing the most distressing event that led to PTSD symptoms, it's important for the clinician to have at least some understanding of what happened to the person in terms of this event. So I mentioned about how you can have multiple types of events, but you want to have at least some understanding of at least one or two of those events. And sometimes you need to do a little bit of probing in order to understand the nature of what happened to the person. One way of doing this is that I've mentioned how intrusive memories of the event are the most common PTSD of all symptoms. If you go to an intrusive memory of the event and you get the person to describe a little bit about that, that can help you understand the nature of the event. You really need, in order to treat PTSD, the clinician has to be able to understand at least some of the traumatic experiences that the person has had. And the reason is that what we're really doing when we're treating PTSD is we're trying to take this kind of like earth-shattering, really difficult experience that people have, that they have difficulty integrating into their lives. And what we're trying to do is to help them kind of make sense of that experience and integrate that experience into their lives. So if you as the clinician can't make sense of that traumatic experience, you're not going to be very helpful in helping the person make sense of it. So that's why you need to spend enough time trying to understand what happened. And you really need at least one clear memory of something that happened in order to treat PTSD. So, and let me talk, now I'm going to go on to one more slide, and this has to do also with the account of the traumatic event needs to at least seem plausible or reasonable to the clinician. And now let me expand on this a little bit. Sometimes you have a plausible account of a traumatic event. By plausible, I'm saying easy to understand, easy to imagine, the kind of event that's reported by other kinds of people. So sometimes what you have is a completely plausible traumatic event, but then it's a little bit confusing because there's a delusional elaboration on it. And so what do you do? So one example, somebody we worked with schizoaffective disorder, had a history of physical abuse and neglect from parents who were had addiction problems, were involved in buying and selling drugs and things. And this account of the kind of physical abuse experiences really seemed completely plausible and consistent with what was known about the client. But the client also reported, kind of as a part of this or a part of her childhood, being kidnapped as a teenager and being forced by a drug gang to fly a helicopter at gunpoint. And this did not seem very plausible. And so this was seen as kind of a delusional elaboration on a traumatic event. In these situations where the core of the traumatic event seems plausible to the clinician, our recommendation is to go ahead with treating the person for PTSD. And when you're doing the psychoeducation and things like that, you focus primarily on the most plausible part. You kind of downplay the delusional elaboration. You may well be able to get to the delusional elaboration later in cognitive restructuring and so on, but it's less critical from the point of getting going in terms of PTSD treatment. And so that's what you do when the event itself seems plausible, even if there's a delusional elaboration. On the other hand, sometimes the account of the traumatic event is less plausible or maybe patently delusional. So, for example, reports of ritual satanic abuse, alien abduction, delusions of control by other people, sometimes reports of sexual abuse with many, many different perpetrators involved over extended periods of time begin to challenge or at least raise questions about the plausibility. And so when the traumatic event appears to be not plausible, that the first thing you should do is try to then refocus, go back to the stressful events questionnaire and to see if there's any other event that the person has experienced that they might have PTSD symptoms to that is more plausible. If the person has reported a history of childhood sexual abuse, but that is not the most distressing event, then what the clinician should do is evaluate whether the person has PTSD related to the childhood sexual abuse. And this is after evaluating kind of the plausibility of the childhood sexual abuse. If no other traumatic events can be identified, the recommendation is not to treat the PTSD that is secondary to a delusional or a kind of implausible traumatic experience. And the reason I say this is that I've actually seen, I haven't done it myself because I think I know better, but I've actually seen clinicians try to treat delusional traumatic events. And what happens is that when you try to treat these, instead of the anxiety related to the event going down, which typically happens in most PTSD treatments, anxiety actually increases and more events become remembered. And you actually have a deterioration in the severity of symptoms and in functioning. And so if the person's PTSD symptoms appear to be related to something delusional or implausible or whatever, the best thing is to steer the conversation away from that and to focus on more practical concerns. So let me stop for just a second and see if there are any questions that people have about the assessment of trauma and PTSD and what you need in order to kind of confirm a diagnosis of PTSD and move into treatment versus what might be kind of warning signals that it may not be PTSD and you shouldn't try treating it that way.
I do have a question.
Go ahead, Adam.
Oh, all right. Thanks, Elizabeth. Yeah, in regards to the timing, I just wanted to ask you to elaborate on when we'd be focusing on assessment and treatment, because I think in the previous slide, it notes that you recommend focusing on this after processing the episode, but I was just working with someone, I'm still new and new to IRT, and I think working through module 2, even within kind of, I think it's topic 4, so we're not even through the assessment and goal planning module, but we've done the stressful life events. And so that came up positive for a few things and felt then compelled to do like the PCL5. So just wondering if it's fair to say like we would assess for this fairly early, but then maybe it would be, we'd focus on interventions and treatment after the processing the psychotic episode, or if I'm understanding that right.
I think you're understanding it perfectly correctly, and I think it is fine to do the stressful events questionnaire, after the second or third session. I think it would also be fine if you postponed it a little bit. If you gave it after the second or third assessment, and then you followed it up with PTSD assessment. If the PTSD was really severe, then you might consider zeroing in on treatment of it earlier. Alternatively, you could do the more formal assessment of PTSD a little bit later. My primary recommendation is that if the PTSD isn't really prominent early on, not to try to bring it into focus of treatment, and actually to postpone assessment of the PTSD symptoms till after the traumatic episode. But it's fine to do the assessment of life events earlier to kind of inform you. And if you suspect that the person has a severe PTSD symptoms, it's fine to assess it. Even if you don't make it a focus of treatment, you could then assess it again, let's say a month or two later after doing processing the psychotic episode. And what you might see is the PTSD related to the other traumatic events go down. Because one of the things we know is that PTSD related to psychotic symptoms or treatment experiences can exacerbate PTSD related to other events. And so it may be that treating PTSD related to the psychotic symptoms results in a significant reduction of the other PTSD, and therefore it doesn't need to be a focus of treatment. I hope it's not too complicated what I said, but the short answer is that your understanding of it and the way you're approaching it really is correct.
Okay, thank you.
Was there another?
I did have another question. Thank you. This is so helpful. And I'm also newish to IRT. What I've come across in a couple situations, and this relates to kind of the plausibility of experiences that folks have had. I'm thinking of two individuals in particular who after some assessment and things like that, it sounds like the people's report of childhood abuse, sexual or physical, sometimes is delusional in nature. But I have a very hard time kind of questioning the plausibility of it. I tend to lean towards, believing the person. So I guess my question is kind of, where does like collateral information come into play? Because let's say this person comes in, my dad has been abusing me, for years. Dad goes, this is not true. I have never done that. It's kind of he said, she said, and this has happened more than once. And so I'm having a hard time kind of teasing apart like the plausibility or like, do I even get collateral information in those kind of cases? Or do I make a report and pass it off to
Right.
ombudsman?
These are really good questions. And it's easy to say there's no easy answers.
Right.
If you have access to collateral information, certainly that can be useful. Collateral information can sometimes confirm a report, but lack of collateral information usually can't, it can't be used to dismiss a report. And so, unless there's something very kind of incompatible, in terms of the lack of confirming, kind of information. I think in the case of reports of childhood sexual abuse that are where there's no external evidence of it, I think the first approach that I would have would be the asking a little bit more to get an understanding of the nature of what the person is saying happened, rather. And so finding out, well, first of all, that a person might have those reports, and then you're gonna have the question in terms of, are they having PTSD symptoms related to those reported experiences? And then if they are, I think that by then what you want to do is to spend a little bit of time trying to understand a little bit about what happened. And so you might have questions such as, can you tell me a little bit about what happened, or when was the last time this occurred, or if you've done the PTSD assessment and the person reports recurring memories of a particular event happening, saying, can you tell me a little bit about this memory, a little bit about what happened, and the person's ability to kind of describe kind of a particular event, you know, like where it happened, that kind of is the way I, you know, that I would try to evaluate the plausibility of it. Now I realize that it's not a sure, there's no sure thing, but sometimes people have vague reports of childhood abuse, but getting into the specifics, it's very difficult to understand any of the specifics. And then that becomes like a kind of a question in terms of the I don't know, the veracity of the report. So my basic argument for it would be, if you can get collateral information, certainly that's useful. But then the second thing is to delve into the reports and to try to spend enough time, get enough of a description of it to kind of make a judgment. And you can also talk it over with other people. Does this seem kind of like realistic? Does it seem plausible, or not? And I realize that that's not necessarily an easy a judgment to make, but the attempt to get that information and the nature of the descriptions and kind of putting them together and where they happen, things like that, can certainly be helpful in identifying some reports as less plausible than others.
Yeah, and it just sounds so, dangerous, right? To kind of assume, you know, if their anxiety symptoms can get worse, if it's, you know, based in like delusional content. It just seems like kind of a sticky situation. Well, of course it is, you know, but
you know, if the initial, I guess the other thing being that I think the advice to explore the plausibility of the report only goes to the extent that it appears plausible. In other words, if from the outset it seems implausible, well, then you don't go and explore it further. If the person says something and it's kind of like, okay, well, this could be happening or not, let's spend a little bit more time trying to understand it, then you're exploring what's at least, you know, possibly plausible in order to get more information to see if the account kind of holds together to some extent.
Yeah, thanks.
Okay, so I'm going to move ahead into treatment. Okay, so the basics of treating PTSD, most but not all of the resources for treating it are in the IRT manual, and I will connect you to a few additional resources to help you in terms of treating it. The basic treatment guidelines that I'm going to be going through are the same as those that are in a program that we call the Cognitive Restructuring Program for PTSD. And this is actually a program that we've done in 2 large studies of people with serious mental illness, but we've used this same PTSD treatment program for adolescents, for people who have been victims of disaster or other kind of mass violence, for people with addiction. So the basics of the program that I'm going to be describing to you are essentially a PTSD treatment program. And it's actually similar to evidence-based PTSD treatment programs in the general population. In particular, it's somewhat similar to cognitive processing therapy developed by Patty Resnick. It at least, you know, uses cognitive restructuring, although our approach to cognitive restructuring is a little bit different. So the core ingredients of this program, which ordinarily, if the person's got PTSD, you would expect between 6 and 12 sessions would be required to treat it. One of the things is that we recommend monitoring PTSD and depression symptoms over time, and I'll go into a little bit more detail. Breathing retraining should have already been taught in IRT, but if it hasn't been at the point that you initiate PTSD treatment, it should. The third component is providing psychoeducation about trauma and PTSD. And then the last is cognitive restructuring, with cognitive restructuring being the most critical component. But we actually know that a subgroup of individuals respond and get a lot better in terms of PTSD symptoms just from the breathing retraining and psychoeducation. But let's go into the specifics, trying to leave the most time for the cognitive restructuring. I mentioned the monitoring of symptoms. What we recommend is giving the PCL, where the person rates the amount of distress they've had over the past week. There's different versions of it, every 3 sessions. So, starting with the first session, at the beginning of the first session, the 4th session, the 7th session, and so on. And what you do is you give it out at the beginning, explain that you're monitoring the symptoms. And then when the person completes the questionnaires, you score it right then, and you spend just a couple of minutes talking about it. If it's in the middle of treatment and there have been improvements, you can get the person's perspective on things that seem to help. If you don't see a lot of improvement early on in treatment, you can normalize that in terms of saying, well, the person's now dealing with some difficult things that they haven't dealt with before. Sometimes it takes a little while for the person to get better. So you normalize that. The use of these questionnaires to monitor depression and PTSD symptoms isn't just to be able to monitor the effectiveness of treatment, but as you'll see later on, it can be useful when it comes to cognitive restructuring, getting at trauma-related beliefs. Okay, I'm not going to get into breathing retraining now, but let me just say, in addition to it being a good anxiety management skill, it seems to have particular use in PTSD because it can reduce the over-arousal symptoms. And having people practice the breathing retraining when they're not super anxious and things like that can have added benefits in people with PTSD. It may reduce arousal and reduce perceptions of threat and fear and things like that. Okay, in terms of psychoeducation about PTSD, this is the one part of the program that is not currently in the IRT manual. And I've put a reference to a book that I co-authored on the treatment of PTSD in people who have experienced post-disaster distress. This is what the book looks like. And in this book, if you get the book, there's an online appendix, and you can download 2 kind of educational modules. Each module's got a bunch of different worksheets. They're separate downloads, but really they kind of go together. So one of them is an educational handout that covers the symptoms of PTSD. And so then there's different worksheets. So you kind of go through the different symptoms, and then there's some worksheets. So my re-experiencing symptoms are this, my avoidance symptoms are this, and so on. And then there's a second educational handout with accompanying worksheets on associated problems related to PTSD. So it could be certain negative feelings, it could be relationship problems, it could be substance use, and so on. And if you get a copy of the book, you can go to the online appendix, download it, and then you can give out these handouts and use it as much as you want with any of the clients that you're working with. And I would recommend that. Psychoeducation is done very much in the same way that it is done for people with the first episode of psychosis, in an interactive fashion, designed to help people relate information about the nature of their symptoms and diagnosis to what is known about the disorder. There's a number of advantages of psychoeducation about PTSD. First of all, it lets people know that they're not alone. It kind of normalizes the fact that many people have had these kind of traumatic experiences, and the PTSD symptoms are also pretty common and part of a well-known phenomenon. So the fact that these symptoms are part of a well-known phenomenon can give hope in terms of there are effective treatments for PTSD, which is certainly true. It also helps people understand that PTSD is not a fault or a sign of weakness. And so for example, people say, oh, I thought I was going crazy, or I think I should have gotten over this by now. And they have very kind of negative thoughts and beliefs about the nature of their PTSD symptoms. So by explaining that these symptoms are part of this constellation of PTSD symptoms and a disorder, what you do is you actually give people kind of a more benign and an easier way of understanding their post-traumatic stress disorder symptoms. So it becomes really useful and can reduce a lot of anxiety and distress just by this psychoeducation. Okay, so that's enough about psychoeducation. Now let's get into cognitive restructuring. Okay, the basic model in terms of, well, why would cognitive restructuring work for people with PTSD? The basic model is following the work of Ehlers and Clark's cognitive model of PTSD. And what their cognitive model says is that when people have traumatic experiences, they develop thoughts and beliefs about those traumatic experiences, but those thoughts and beliefs also extend to thoughts and beliefs about the world, thoughts and beliefs about other people, as well as themselves. And interestingly, many of these thoughts and beliefs are threat related, like the world is unsafe or you can't trust anybody, but some of them are self-related. They're not related to outside threat, but things like, oh, I'm a weak person, I'm a vulnerable person, I have no future, I'm tainted, the event or the events are my fault, and things like that. And that the persistence of these trauma-related thoughts is what accounts for the PTSD symptoms. So in the use of IRT and cognitive restructuring in the treatment of PTSD, what you do is you essentially go to the managing distress module, which is where the 5 steps of cognitive restructuring are incorporated. And you just might find it interesting to know that we actually first developed the 5 steps of cognitive restructuring when we were developing this PTSD treatment program for people with serious mental illness. And we found that this approach to teaching the 5 steps of cognitive restructuring, beginning with, with cognitive, common styles of inaccurate thinking, and then the 5 steps of cognitive restructuring, we found it such a useful approach that you could use it with people who didn't have PTSD. You could really use it to help people deal with any distressing feelings that they were having. So, now let's get into the issue of trauma-related thoughts and beliefs. So what you do is when you introduce the 5 steps of cognitive restructuring, you explain that this can be a useful approach for dealing with distressing feelings. And you explain, where distressing feelings come from and the whole, thought, feeling, behavior triad. And then you go about teaching the 5 steps of cognitive restructuring as an approach for dealing with distressing feelings. Any kinds of distressing feelings. Oh, 1 second here. So the idea is that you're first trying to help the person develop skill at addressing negative feelings. Now, sometimes from the outset, the negative feelings that come in and that they want to begin addressing are trauma related. And you always follow the most distressing feeling and the thoughts related to that. And so sometimes you're actually dealing with trauma related stuff, like almost from the get-go. And that's fine. You never say, oh, well, we got to put that off. We'll do that at a later point. You kind of take what you're presented with. At other times, what happens is that you're helping them use cognitive restructuring to deal with day-to-day negative feelings and things that aren't necessarily trauma-related, and that's fine. You're helping them develop the skill at doing that. And then one of 2 or a few things happens after that. Sometimes as people get more skilled at doing cognitive restructuring, the trauma-related thoughts and feelings naturally kind of creep into the picture. Because if the person has PTSD, they're having distress related to thoughts and feelings. And if you're following the distress, it will often just lead you quite naturally to trauma-related thoughts and feelings. Sometimes, even as the person is getting better at using the 5 steps of cognitive restructuring, trauma-related thoughts don't appear. And there are a number of different strategies for bringing them into focus, which I will talk about in just a minute. Because we've been talking about the 5 steps of cognitive restructuring, I wanted to just give one example of the use of the 5 steps for addressing a trauma-related thought, just to give you kind of an example. You might even think of it as a prototypical example of the use of the skill. It's from a real client and everything like that. And then what we'll do is we'll go into talking about how you bring a focus onto PTSD thoughts, as well as how you dispute them in cognitive restructuring. So the example here, let me tell you a little bit about this situation. This was a guy who had developed a severe mental illness. His traumatic event was that he had been in the Navy and that he was out to sea. And for some complicated reason related to his housing situation, he did not have his own room. He was bunking with somebody who had offered to let him bunk there. And he went out drinking one night, came back drunk, and was essentially sexually assaulted by his roommate, male roommate, while another person held him down. And then this led to a great deal of confusion on his part. He then pursued, he thought maybe he was gay. He then pursued a sexual relationship with this person and decided he was not gay. And so he had a combination of negative feelings around the sexual assault and the behavior afterwards, including guilt and shame, but also some feelings of fear. And so that was the nature of the traumatic event. And so this is a cognitive restructuring. The situation here is thinking about the sexual assault. And that is a kind of a situation, because, maybe the memory of the sexual assault pops into the person's mind. It's upsetting. And so that's the nature of the situation. So the situation was thinking about the sexual assault. The strongest feeling that he had associated was guilt and shame. So then when it came to identifying thoughts, of course, we try to get people to come up with a number of different thoughts that are related to the upsetting feeling in that situation. And then the idea is that you then focus on the most upsetting of the different thoughts. So the first thought was that I am responsible for the sexual assault. The second thought was that I'm a sick, twisted, weak individual who acted against his own principles. Here he's talking about the sexual relationship. And the third is that I'm disgusted because I engaged in a relationship with another man. And the most upsetting thought was the first one. I'm responsible for the sexual assault. And in terms of common style of thinking, he identified it as possibly all or nothing thinking. Okay, so then this is just a repeating of the most upsetting thought. So then the things that he said did support his thoughts were that he was drinking that night and passed out, and then that he engaged in a consensual relationship with the person following the assault, and that he should have known better, that he was a friend, and he shouldn't have been hanging around with the person, but he needed a place to live. He saw all of these as supporting the thought. Of course, we know that the evidence isn't great for all of them, but for reasons I could go into, you don't want to have a lot of debating of the evidence during the initial kind of brainstorming stage. When you are evaluating the evidence, that's when you want to pay more attention to strong evidence. Okay, the things that didn't support his thought were it was against his will, he was held down by one person, raped by another, he didn't want to be raped, he was unable to protect himself, he was in a compromised situation, and he had no reason to suspect that a friend would do this to him. And then in terms of did the thoughts mostly support or not support the evidence, did the evidence mostly support it or not support it? He judged that did not mostly support the thought. And then the new thought was, now it's always important that the new thought is believed more than the old thought. And sometimes the evidence that the person has supporting the old thought can be incorporated in a way into the new thought to make it more believable. So remember, in this case, the guy felt, well, it was his fault, because he was drinking and things like that. And it wasn't really his fault, like, in a moral way, but there were things that he did that put him into that situation. So the new thought has an acknowledgement of that. While my drinking in other circumstances may have put me at risk, I'm not responsible for the abuse. So this is an example of where some of the evidence for the old thought gets incorporated into the new, much, much more balanced thought, where the central message is he was not responsible for it. Okay, so that's a demonstration of it. Okay, so now let's talk about how to get at trauma-related thoughts and a few pointers at how to help people challenge them. So the first bullet here is simply that often trauma-related thoughts quite naturally present on their own as people get better at using the 5 steps of cognitive restructuring. A second strategy is that you are, by routinely monitoring the PTSD symptoms and reviewing the PTSD symptoms, every third session, you can bring a focus to a particular PTSD symptom that the person has recently experienced that will then bring you to a trauma-related thought. So, for example, we've talked about how intrusive memories of a traumatic experience are probably the most common PTSD symptom. So if you gave the PCL to somebody, and let's say you've spent 3 or 4 or 5 sessions with them on cognitive restructuring, they're kind of learning it, but trauma-related stuff hasn't come in. So then you give the PCL, you score the PCL, and you talk about it for a couple of minutes, and then you say, I noticed, over the past week, you reported, moderate levels of distress when due to experiencing intrusive memories of this event. Maybe we could work on that a little bit. When was the last time you had this memory? And boom, you go into cognitive restructuring. The situation is the person's having a trauma-related memory that is upsetting to them. And so there you are at a trauma-related memory and the meaning and interpretation of that. So that becomes another way of bringing trauma into focus through the monitoring of PTSD symptoms. A couple of other strategies. Sometimes you may have an idea about a particular thought related to an upsetting event that might be trauma related, but you're not sure. And so just asking, you can say, oh, is this particular thought related to this particular traumatic experience? Or sometimes the person will have a theme. They'll have multiple cognitive restructurings around distressing events, about the person being able to being blamed, or situations where there's a fear of shopping, fear of interacting with men, and things like that. And you suspect, or you think maybe it's related to the traumatic event, but you're not sure. And so what you can do is you can ask about it. You can say, I noticed that this happened, and that we've done a number of the different situations that have been upsetting have involved this, that, and the other thing. And I'm wondering, is this related to your traumatic experience? So you're not imposing it on the person, but you're kind of bringing it up. You're bringing it into the conversation. Also, in the worksheets from the PTSD psychoeducation, one of the worksheets we have is trauma is called How Trauma Affects Our Thoughts and Feelings. And you actually complete this. Remember, one of the symptom clusters of PTSD is alterations in thoughts and feelings. So it's only natural when talking about this to help the person identify what some of the thoughts and feelings they have that are trauma related. And so you can bring this worksheet out that was completed during psychoeducation and zero in on one of the thoughts and feelings that way. Last of all, there is a standardized measure of post-traumatic cognitions called the Post-Traumatic Cognitions Inventory, created by Edna Foa in 1999. And you could give this, and I think there's like 36 different kinds of traumatic events, and you could identify a traumatic event from that as related to the person's traumatic experience and use that as a focus of cognitive restructuring. I'm going to mention one or two other strategies, and then we'll open it up for some questions. So those are strategies for how to bring trauma-related beliefs into focus when doing a cognitive restructuring. I now want to just say a few things about, actually, this next one is also about how to get to a trauma-related thought. This is called the downward arrow approach. And this is a kind of a classic CBT strategy that's aimed at getting at core thoughts or beliefs underlying upsetting thoughts, otherwise known as getting at schemas. And the idea is to ask questions about an upsetting thought that a person has, aimed at understanding more about the nature of that upsetting thought. And so the idea is that you ask a question about an upsetting thought in order to understand what is so upsetting about it. And so here's just an example. The client says, the clerk yesterday at the store looked at me like he was going to assault me after I left. And the therapist said, if that's true, what does it say about you that would, sorry, I can't read the whole thing. That would, that would, okay, what is it about you? In other words, the person is looking at them. So the therapist says, what does it say about you that would possibly happen? The client says, well, that he might somehow peg me as somebody who is weak and could be taken advantage of. And then the therapist says, okay, if that was the case, what might that say about you? So rather than just focusing on, oh, the person is pegging me as someone who is weak, the downward arrow question is saying, okay, what does that mean about you? What does that say about you? Well, people just know. Well, what do they know? Well, everybody knows that I'm worthless because my dad beat me up, or something like that. So it's a way of getting at more upsetting thoughts by asking about the meaning of upsetting thoughts in a kind of a sequence of questions. One last thing about challenging trauma-related thoughts is that sometimes it's a little more difficult to challenge a very, very general thought than it is a more specific thought that is related to a traumatic event. So I'm a shameful person, for example, is a little bit harder to challenge than I'm a shameful person because I didn't tell anyone about the sexual abuse and I should have. Or I'm shameful because I didn't stop the sexual abuse and I could have. Or I'm shameful because I had some sexual feelings, which means I'm bad or not normal. Each of these more specific statements linking a more general thought or belief to the traumatic event is much easier to dispute in terms of looking at evidence for and against. Or because I was physically abused by my parents or boyfriend, nobody can be trusted. Or, I have to be on guard all the time because I was abused as a child and have been assaulted as an adult. So the first one is, well, in both these cases, these are, related to a more specific connection to the traumatic event and the belief. Okay, the last thing is just a couple of kind of pointers. I've already talked about the first one, that you need to understand the nature of the event. Often it's important to prompt the person to consider what is similar and what is different in their lives when the trauma happened then and now. This is especially true for events that happen in childhood. People will look at themselves as though they're still children, as though they are still vulnerable, when actually they have much more control over their lives as adults than they did before. Look for exceptions to absolutist beliefs, however minor. If a person believes nobody can be trusted, if you find just one person who can be trusted, you're already beginning to chisel away at that belief that nobody can be trusted. Focusing on gradually weakening core trauma-related beliefs by review of the evidence is often helpful in gradually eroding beliefs, as opposed to looking for a huge change in the nature of the belief, although sometimes those changes can happen. Whenever you come up with help a person come up with a new thought, and the idea is you're trying to help the person at least raise some questions about the accuracy of the old thought. If the old thought is seen as being even somewhat less accurate than was previously thought, then the idea is to try to come up with a modification of the old thought that is more accurate. And once you're sure that it's more accurate, you can check with a person. You can even use like ratings and so on, then to check with the distress. And more accurate thoughts are almost invariably associated with reductions in distress. If not, then more examination needs to be done. But that's generally what is useful. The very last thing I'll say is don't avoid going into action plans when a person decides that the evidence supports a distressing thought, or the person may change their thought, but the new thought may still be somewhat distressing, and an action plan may be warranted. Here are a few situations where action plans are needed. Sometimes you need to get more information about a concern. Does a therapist dislike me because they canceled 3 appointments? And you just might not be able to judge that, and so an action plan might be getting more information. Sometimes you need an action plan to solve a real life problem. The client wants to attend a family reunion, but there's a cousin who abused her who will be there. So you kind of want to come up with the action plan. Sometimes there is significant distress related to PTSD symptoms, even after you have done cognitive restructuring. So let's say a person has a lot of trouble sleeping, and then they have some catastrophizing beliefs. I'm never going to get a good night's sleep. My life is wrecked because of this. And so you do the cognitive restructuring, see the person is, catastrophizing, reading into the future too much. You come up with a more accurate statement. Well, it's upsetting not to get a good enough sleep and to feel really tired the next day. Okay, more accurate thought, less distress, but there is still some distress. So now you go into developing an action plan around the feeling of distress when the person doesn't get enough sleep. And that can lead you into, for example, sleep hygiene. So action plans are actually how you get into the broad range of different coping strategies for persistent symptoms with PTSD. You can also use action plans to kind of problem solve obstacles to achieving goals, like finding places in order to meet new people, to find new friends, and so on. Okay, let me stop and open it up for questions. I'll just leave the summary slide here, but why don't we see what questions people have?
I have a question, Kim.
Yep.
I guess I'm wondering a little bit about when PTSD, like sensory sensory flashbacks maybe are reduced as a result of like going through these treatment modalities, but perhaps emotional flashbacks remain, like remaining rage, these sorts of things, but that have been decoupled from the sensory features of flashbacks. Wondering if you could speak to that a little. It's something that I don't understand so well just yet.
Yes, I'd be happy to. Now, I'm not 100% sure I'm construing your question exactly properly, but your question brings up a really, really important thing, and that has to do with dealing with anger in cognitive restructuring and treatment of PTSD. And so let me talk about that, because anger is a little bit of a tricky emotion, and you can definitely deal with it, but it's a little bit different. And let me explain why. Generally speaking, and this applies, by the way, to working with anger and cognitive restructuring, even aside from PTSD, but I'm going to talk about it in the context of PTSD. Anger is a little bit different than the other negative feelings when it comes to cognitive restructuring, because when people are angry, the feelings associated with anger are often very reinforcing. People feel, first of all, blame is externalized as opposed to internalized. People are energized. And so as a result of feeling angry, people kind of want justice and things like that. They often don't want to re-examine and challenge thoughts and beliefs that they have. And so even though we kind of conceptualize anger as a negative feeling, you don't have the same motivation that people have to change anger as they have to change things like anxiety, depression, and so on. So you have to start off with that recognition that anger doesn't feel bad in the same way. Sometimes with a really good connection with a person, what you can do is you can help the person see the anger as kind of a defense against underlying feelings of threat and anxiety and so on. And by doing that, you can get at that. At other times, that's hard to do. And what you need to do is to try to link the person's experience of anger to interference that it is causing in other parts of their lives. It might be hard to get close to people. They might have been physically, aggressive or something like that. It may lead to anger outbursts that lead to problems at work or at school or with other people. If you can get the person to see that the anger that they're experiencing is getting in the way of other important goals, then you can get them to buy into addressing anger and really examining the thoughts and beliefs underlying these angry feelings, not because the feelings feel bad, but because they're leading to behaviors that are interfering with other things that the person cares about in life. That's the general stance that to take in terms of anger. There are many other strategies, and in fact, in the PTSD book, in the special, there's a section, the third chapter on cognitive restructuring. We get into a whole bunch of strategies for dealing with persistent feelings of anger that people have, sometimes after the perpetrator has died and things, that people hold on to the anger. And there's a bunch of different kind of creative ways of using cognitive restructuring. One of the ways is, for example, evaluating the pros and cons, doing a payoff matrix, so to speak. What are they getting out of maintaining this anger? So sometimes I call this the Captain Kirk, anger, because in one of the Star Treks, there's this guy who comes and he's going to take everybody's negative feelings and stuff like that. He's going to make it all go away. And Captain Kirk goes, no, I need my anger. I need to hold on to my anger because it protects him. By maintaining the anger, he's less likely to be victimized again. He needs to hold on to that. And so when that is the purpose of holding on to it, then you're down to identifying a fear-related thought. I'm likely to be victimized again if I don't let go of this thing that happened. And then it's kind of like, okay, let's examine that. How likely are you to be victimized again? And then it's a much more easily addressed kind of thing. So those are the basics about dealing with anger. Is first of all, recognizing that it's not negative in the same way, trying to partner with the person around addressing it. And then sometimes that's all you need, but then sometimes you need to get at the functions of anger. What's the role that it's playing in the person's life? And that can lead to other thoughts and beliefs that are actually easier to address in cognitive restructuring than the more surface ones that you've identified.
Thank you.
Sure.
We want to be mindful of time. We're at 9:30, so if people need to go, we can go ahead and wrap up.
I'm happy to stay for a minute or two if anybody wants to ask another question or two. I realize that I probably didn't leave enough time for questions, but what can you say?
Yeah, certainly if there are folks that have additional questions and you want to stay on for a few more minutes, we can do that as well.
This was so helpful. I really just appreciate it, kind of breaking it down a little bit further. There's a lot of folks who come in saying, I have PTSD, and sometimes they may not meet criteria anymore or might not know what it is. So this is all really helpful. Thank you.
Yeah. I got to say something, if not controversial, maybe a little bit paradoxical, but a funny thing about PTSD is that when people come in with a lot of trauma in their background and they want to talk a lot about trauma, they may well have trauma issues, but often they don't have PTSD. I mean, the cardinal symptoms of PTSD are avoidance. They're the people who they don't want to talk about it. And so it's not coming out all of the time. And so you still need to help people who want to talk about this stuff kind of have ways of dealing with it and so on, but it's not going to be the same as the treatment of PTSD. And that has led to this is my kind of paradoxical comment. I think I told this to Piper the other day, which is, which is when people have had a lot of trauma issues, if they want to talk about it a lot, don't, because it's not all that useful. I mean, you have to talk about it a little bit. And if they don't want to talk about it, do. That's my little rule of thumb. Yeah.
I love that. Is this something that you plan to put on like a semi-regular basis? I could just see how, especially as a newer IRT, like coming back to this content.
I'm so happy that you guys are doing Navigate, and I'm happy that Piper invited me to this. I would be happy to come back at any time. And by the way, we are now, our book where we laid out the PTSD model for everybody, unfortunately, is out of print, but we are doing a book on just treatment of PTSD in people with serious mental illness. But to answer your question more directly, I'd be happy to come on really with any frequency. Just let Piper and Carissa know.
Yeah, thank you so much.
Sure.
Well, all right, guys, thank you so much for joining us today. We have 2 more clinics left in this series in the month of June, and then it's sort of TBD on whether or not we will be able to continue the twice monthly echo clinics. My hope is that we will, on some level, be able to continue to have these opportunities. Thank you so much, Kim, for coming today. Really, really, really appreciate it. I know this topic has been one that people have been asking for since we started doing these echo clinics like 12 months ago. So I'm glad that we made it happen. And yeah, everybody have a super excellent day. So thank you.
Nice to meet everybody.
Bye now.